I'm going to deal with failures of metal-metal bearings and touch briefly on the question of would another bearing couple do better? These are the innovators who developed successful metal-metal total hip replacements in the 1960s. I've had the privilege of following up patients who have had these innovators' designs of metal-metal total hip replacements. And I know the lady in the middle very well. 15 years ago, I replaced her opposite hip. I can tell you that she's now in her early 60s, and her left metal-metal total hip replacement is perfect 40 plus years down the line. So these implants can work very well in the long term. This is a metal-metal ring that I revised 23 plus years after Peter Ring inserted it into a lady with developmental dysplasia. I revised her eventually because of cup loosening, but she led an extremely active life. And here are the implants and an assessment of wear on those implants, and you can see that the wear is extremely low. I draw your attention to the fact that there's a high clearance and point out that high clearance is entirely consistent with low wear in the long term. Professor Duncan Dowson has taught us that with 15 years of use, metal-metal hips produce a volume of metal debris equivalent to one pinhead over those 15 years. Now, the volume of a pinhead is 0.88 cubic millimeters, so that's not a lot of wear in 15 years of a normal metal-metal bearing. I'm going to talk about failures, but before I talk about failures, it's important to put this in context. And here are my 3,095 Birmingham Hip Resurfacings, and they've done reasonably well. I have over 600 men and over 300 women at 10 years, with a 10-year 97% survivorship. Now, I would like to compare my results to the national registers, but it's not a fair comparison on account of experience. There are now 3 cohorts of patients on the Swedish register, and slowly they have removed failing implants. They have restricted implants with no history to experimental use, and as the years pass, they have slowly improved their surgical techniques. Here are some patients who are included in my series. Avascular necrosis, cysts in the femoral head, dysplasia, dysplasia with femoral head bone loss, dysplasia with high femoral torsion, dysplasia with previous surgery. I now know that all of these conditions increase the failure rate, but these and many other patients are included in my series. I haven't got the luxury of a first, second or third cohort. All of those patients are in my first cohort of Birmingham Hip Resurfacings. But despite that, and the higher failures that you get in certain subgroups, my overall results compare favorably to the Swedish register for both cemented, uncemented and hybrid total hips. Young men with osteoarthritis are a particularly difficult group, and you can see 81% survivorship from the Swedish register with total hip replacement. Now, of course, the Swedish register have over 4 times the number of my patients, but I do have 270 patients who are now at 10 or more years with a 98% survivorship in this tough cohort. Clearly, my results are out of line with common treatment, and there is every reason for those who do not like resurfacing to have special conferences, international scrutiny, and press attention to dampen enthusiasm in this treatment method so that we can all wallow in the same mediocrity. I'm going to talk about periprosthetic tissue reactions, and these have been given different names by different groups. Pseudotumors is particularly unfortunate, and the press have had a field day with this, and you can see here tumor fear over metal hip replacements. This has put quite unnecessary fear and alarm into our patients. Pseudotumors are caused by edge wear of the cup, and edge wear is caused by poor design or poor surgery. This is a slice through the BHR cup and the ASR cup. Here you can see the different subtend angles, and the fact is that the ASR has 12 degrees less articular surface compared to the BHR. Now we all know that the results of the ASR have been poor and the device has been withdrawn. This is the alert from the MHRA last week, and it says here, do not implant depuis ASR hip replacements. I've been telling surgeons this for 6 years, and for nearly 5 years this advice has been on my website. If removal of articular surface from a cup is bad, could we improve matters by adding articular surface? Unfortunately, there's not a lot of scope for adding more articular surface, but Harlan Amstutz has managed to add between 1.1 and 1.8 degrees to the coverage angle of the Conserve Plus compared to the BHR. The problem, of course, is that the more you add, the more chance there is of impingement between the femoral neck and the edge of the acetabular cup. This is Harlan's report on his first 100 Conserve Plus hips. 21 of the patients had signs of neck socket impingement. However, the patients do not seem to have been harmed by this, and he had no pseudotumors in his first 100 patients. I have seen occasional impingement lesions with the BHR. This is one patient who was extremely active, and you can see the impingement lesion on his superior femoral neck. We've shown on the bottom right flexion to 90 degrees and full abduction, and you can see that the impingement lesion has been caused by impingement of the superior neck against the posterior edge of the acetabular component. Now, this patient was extremely active, came back to have a second side done, and was involved in all sorts of impact sporting activity. This is where you would like the wear on a metal bearing cup to be, in the articular surface. This is where you do not want the wear on a metal bearing to be, at the acetabular edge, because the wear goes up tremendously. This is a BHR that has been removed with a pseudotumor, and the cup had been implanted in a high inclination angle. I just want to demonstrate to you that the amount of wear that you get with edge wear is visible. Here's a close-up, and you can see that superiorly the wear has gone right up to the edge of the laser marking on the cup face. Inferiorly, you can see the lack of wear for comparison. On scanning electron microscopy, the edge of the cup is destroyed. We've had the wear measured with detailed measurement, and there's the linear and volumetric wear. Now that amounts to 253 pinheads worth. Remember that one pinhead's worth of wear occurring in 15 years is the normal. This patient had 253 pinheads worth in half that time, so the rate of wear is 500 times the normal when you get edge wear off the cup. If you want to destroy a metal-metal bearing rapidly, then put it in with a high inclination angle and you will get tremendously high wear. No surprise then that the soft tissues get damaged by large volumes of metal debris given off in a short period of time. This is where we would like our cup to be inserted. This is not where we want our cup inserted. This is 55 degrees of inclination, and for the BHR, this represents a top safe limit. If the patient's femoral head size is large, then he may get away with it. But if the femoral head size is small, for example in a woman, then it is highly likely that edge wear will occur with a soft tissue reaction. How have I personally done with my cup inclinations given that piece of information? Here are my first BHR implantations, and you can see that in the early days I was aiming for 45 degrees of inclination, but I started to notice some outliers at or above 55 degrees. I hated this and acutely reduced my target inclination angle, and I stayed there for a while, but then I started to notice that some outliers at the bottom were too low. So gradually I reverted to targeting 40 degrees. On the right you can see from our published work the inclination angles in my year 2004. I have targeted 40 degrees and all my inclination angles are within the range plus to minus 12 degrees. This is a publication from Oxford, the 5-year results of the Birmingham Hip Resurfacing Arthroplasty, an independent series. Now, despite this being a comprehensive review, unfortunately, they did not declare what the cup inclination angles were for the 37 surgeons who did this work. Now, that publication marked a high point for Oxford. They unfortunately have published a mass of papers, firstly relating to death of bone in the femoral neck and in the femoral head from a flawed surgical procedure, and then followed pseudotumor publications and more pseudotumor publications. In one pseudotumor cohort, their acetabular inclination angles were 22 to 75, and in another cohort, 10.1 to 80.6 degrees precisely. Their publications ended with advice to us on optimal acetabular orientation for hip resurfacing. You do not need to insert a cup at 75 degrees of inclination to get a pseudotumor. This is a man in his 30s who came from abroad, and I inserted the resurfacing that I was doing at the time 15 years ago. It's not an ideal design, but he's had a great result that you can see in his right hip. By the time that he needed his left hip resurfacing 4 years ago, they were doing hip resurfacing in his own country, and you can see he's had a BHR inserted with 63 degrees of cup inclination. He's now got a hip full of fluid and pain, and he needs revision. Very unfortunate, all caused because the cup has not been inserted at the correct inclination angle. Here is the same implant, the BHR, with different surgeons. Tony Nargle has inserted 155 BHRs, and he has had no pseudotumors. These were the first resurfacings that Tony inserted, And this, of course, represented his learning curve. But despite that, no pseudotumors. I haven't done quite so well. In 3,095 BHRs performed up until the end of 2009, I've had 10 representing 0.32% pseudotumors. David Murray and 36 others in 643 BHRs have almost 8 times the prevalence of pseudotumors compared to myself. When we look at the same surgeon, again, Tony Nagel, using different implants, this is very revealing. He got his learning curve in with the BHR. He's a very careful surgeon. He's measured all his angles, and he has no pseudotumors with the BHR. Then, having got his learning curve in, he's moved on to the ASR. Again, he's shown his angles, and unfortunately, he has 6.4% pseudotumors. I wish to point out that in my series, when we consider all the failures I've had, pseudotumors are less of a problem numerically than infection, than fractured neck of femur, and femoral head collapse. The Oxford group have reported in their pseudotumor series severe muscle damage, 50% serious complications with revision surgery, 31% re-revisions, and poor functional outcomes. In my pseudotumor series, despite the fact that they are given the same term, they appear completely different. I've had 9 fluid collections and 1 acetabular osteolysis. I've seen no muscle damage. There have been no serious complications following revision surgery, no reoperations, and good functional outcomes. So my pseudotumors seem to be much less severe than have occurred in Oxford. Here is one of my pseudotumor ladies, and you can see that she has femoral neck thinning at 10 years. There is fluid in the psoas bursa. Here are all her angles. Now you can see that her cup inclination is 35 degrees. That's fine. Her anteversion of the cup in isolation of 27 degrees is fine. But when you combine that with her femoral neck anteversion of 30 degrees, then the combined femoral neck and acetabular anteversion is well over 45 degrees. I want to point out to you that this is not a regular CT scan. This is a multi-slice CT scan with lots of slices and metal artifact reduction software. If you do a regular CT scan in these patients with metal, then you will just get a mass of artifact lines. I and my radiologists for 10 years have preferred multi-slice CT scan with artifact reduction software to, for example, MRI scanning or ultrasound scanning, because you can see the soft tissue element of pseudotumors, you can see osteolysis, and you can measure accurately component position in 3D. This is another lady with a metal resurfacing that I've done, who has a pseudotumor, as outlined by the arrows. You can see that her inclination angle is fine, but her combined femoral neck and acetabular anteversion is too high. Her metal ions were raised compared to a normal functioning group. I revised her to a ceramic on polyethylene articulation, and 2 years down the line, her pseudotumor has gone and she has excellent function. I did nothing to the pseudotumor. So in my pseudotumor series, the inclination angle measured from 29 degrees to 43 degrees. So I haven't fallen into the trap of high inclination angles getting edge wear superiorly. However, the thing that has tripped me up are women with minor dysplasia where the combined femoral neck and acetabular anteversion is too high. You can see here that all but one of my combined anteversions are greater than 45 degrees. So I have one patient in my whole series whose pseudotumor cannot be explained on the basis of mechanical malalignment. I just want to show you my worst pseudotumor in my own series. And this is a lady who was great for almost 10 years after her BHR, but then she developed swelling in the groin and symptoms which were disturbing. And her X-ray, as you can see at 10 years, shows acetabular osteolysis. Now I've had to revise her hip to a total hip replacement and bone graft her acetabulum. But I just wanted to show you the early functional recovery in this lady who represents my worst pseudotumor. This video was taken when the lady came for her 2-month postoperative review following her revision surgery.
I was in hospital for 5 days. I think I actually left on the 6th day. The wound healed fine. I didn't have any weeping or anything like that. It was absolutely fine. And on the day that we went home, my son actually cooked supper for us. But then the very next day, I just got back to normal and I was using one crutch around the kitchen, cooked supper. And then the day after that, so 3 days out of hospital, I went to the supermarket and did a proper shop. We went to New York 6 weeks after the operation. We walked for miles in New York and used the subway a lot. And I just didn't give it a second thought. I used one crutch whilst I was there, just for security, but I don't think I really even needed that. Central Park's quite up and down, and it was absolutely ghastly weather, and it was slippery and, very muddy, actually, believe it or not. In fact, I was walking better than my husband and my daughter, so, it was easy. I feel very confident with it, very comfortable with it. I've walked for miles, and I haven't had any feeling of insecurity with it at all. It's just very easy.
I want to briefly talk about hip resurfacing in women, and Oxford have pointed out that in their series the risk of pseudotumor is particularly high in young women. They say the cumulative revision rate for pseudotumors in women under 40 years was 13.1% at 6 years. Now that information from Oxford has pretty well stopped surgeons around the world carrying out hip resurfacing in young women. I still carry out hip resurfacing in women where the bone stock is good as the treatment of choice. Here are a rather larger series of women of mine compared to Oxford who are under the age of 40 years at operation. And I need to point out to you that primary osteoarthrosis in the main does not occur in young women. They have sequelae of childhood disorders and some avascular necrosis just thrown in to make life more difficult. The young women typically have AVN secondary to treatment, let's say, of a non-Hodgkin's lymphoma, tumor-free 4 years after treatment, but 2 osteonecrotic hips. So all of these women present different and difficult technical challenges. Now, 95% survival at 10 years when 50 plus patients have got to 10 years is not fantastic, but compared to other treatment modalities in this tough group, I think a 95% survivorship in these young women is perfectly acceptable. Very importantly, not a single woman in this group developed a pseudotumor. So my series is completely contradictory to Oxford. I have more patients, the diagnoses are tough, but they have no pseudotumors, and I continue to treat young women with a Birmingham hip resurfacing. Oxford have pointed out that the prevalence of pseudotumors in their asymptomatic resurfacing patients is 5%. They've scanned with ultrasound 95 hips at a mean of 58 months. We have looked at this as well, and we have multi-slice CT scanned my asymptomatic patients, the first consecutive 124 BHRs that I've done, who were all beyond 10 years of follow-up when they had their scan. There are no pseudotumors in that group. So the Oxford material would give the impression that there are a lot of hidden pseudotumors which may rear their ugly head and require revision surgery as the years pass. My series does not give that concern. Now, Oxford have talked about the preoperative head-neck ratio as a risk factor, and they point out that if the head-neck ratio is above 1.35, then the patient is at risk of developing a pseudotumor following a hip resurfacing. I don't fully understand this, but we have looked at the head-neck ratio in our series. My control group is a group of women with BHRs who have 10 plus years of follow-up, are asymptomatic with good hip scores, with metal ions within the expected range, and having had a multi-slice CT scan at 10 plus years with artifact reduction software showing that they have no pseudotumor. There are the head-neck ratios on the left in that control group of women, and you can see that there are a lot of women with a head-neck ratio preoperatively above 1.35, and they are proven not to have a pseudotumor in the 10 plus year stage. You can see on the right the preoperative head-neck ratio in my 10 women with pseudotumors, and the head-neck ratio in the pseudotumor group is not significantly different to the head-neck ratio in the non-pseudotumor group of ladies. What we have seen, however, is that there is a tendency that as the head-neck ratio increases, then so too does the femoral neck anteversion. So here's what I think is going on. I think the increased head-neck ratio is only one subtle sign of developmental dysplasia of the hip. In itself, the increased head-neck ratio does not affect the outcome of hip resurfacing, but the association between head-neck ratio and increased femoral neck anteversion is highly relevant, as I've already shown you, to the outcome of hip resurfacing. So I don't think you need bother about head-neck ratio in the preoperative assessment of patients. It's much more important to consider the femoral neck anteversion, and you can measure this either with CT scan preoperatively or assess it intraoperatively, and then you must adjust the acetabular anteversion to match the increased femoral neck anteversion so that the combined femoral neck and acetabular anteversion is not above 45 degrees. The current BHR has a 6 millimeter outer diameter to inner diameter difference. So if we put in a 52 cup, and that would be typical in a woman, you would use a 46 head. So we do indeed downsize the femoral head by 6 millimeters on average in every patient who has a resurfacing. The only way currently of increasing that femoral head size is to overream the acetabulum to get a bigger cup in, which allows you to put a bigger femoral head in. In my book, it is unacceptable to overream the acetabulum in these young people. We have tried to address this, and we have a new cup which has been designed with a 2 millimeter OD-ID difference. So the 52 cup would now have a 50 head that matches it. We know that the average BHR head size for men is 50 millimeters, and men very, very rarely get edge wear and a pseudotumor. The average BHR head size for a woman is 46 millimeters, and it is women who are at risk of pseudotumor. The smaller the head size, the more accurate the surgeon has to be to get the acetabular and femoral alignment all matched up. With the new cup, then 50 millimeters will become the average resurfacing head size for women, and this will give much more freedom for minor cup component malposition and still avoiding edge loading of the cup. If we now address the same surgeon with different implants again, all these have been done by Tony Nargle. If you were concerned that the pseudotumor rate in the ASR resurfacing was high, then if you match an ASR with a total hip stem, the pseudotumor risk is 3 times higher. This is an ASR cup on an SROM stem done by Tony Nargle, and he is a very good surgeon, and I cannot see anything that he has done wrong there. But this patient and 13 others like her developed a pseudotumor. If I look at my series of metal hips, since October 2001, I've inserted 653 metal total hip replacements. I have had 1 pseudotumor in that series of patients. There is that patient, and she developed a pseudotumor 4.9 years post-op, and I didn't think I'd done anything too wrong, but as I'll show you, unfortunately I did. Her metal ions are slightly up. There is the fluid in the psoas bursa. There we are at operation, and you can see metal staining in the synovium. Now, where's that come from? In this particular patient, it has not come from the taper, it has not come from impingement, it has come from age wear of the cup. And you can see the typical roundness pattern showing edge wear of the acetabular cup. How did that happen? Here's our multi-slice CT in that particular patient, and again you can see that I've fallen into the trap of allowing too high a combined anteversion of the femoral and acetabular components, giving anterior edge wear of the cup. The causes of pseudotumor in metal total hips is either edge wear of the cup or failure at the neck taper junction. I want to point out to you that failure never occurs between the outside of a sleeve and the inside of a head. The failure always occurs between the inside of the sleeve and the neck taper. Now, the taper cone was introduced by Robert Jude in 1969, and here's some of the early pictures kindly given to me by his son, Professor Thierry Jude. Cones in the early days were thick, chunky pieces of metal, but they have been modified with time. With ceramic bearings, we first noticed that there was impingement between the acetabular component and the femoral neck. Then the femoral neck was trimmed down a little to try to get over this impingement problem. And then people wanted to use rather smaller heads, and the taper and the neck were reduced in diameter. Then people wanted to use very small heads, and you can see in the bottom left that in that situation the taper is protruding beyond the lower margin of the head, giving a poor head-neck ratio. So the taper has been shortened back, and the situation bottom-middle is much better for small heads. But if you now implant a large head with the current iteration of tapers, then compared to the historical norm, the taper diameter and the taper length has been reduced, and this gives a fairly dramatic reduction in the available surface area for fixation in the taper junction. The companies have been quite open about their modification of tapers over the years, and the V40 taper happens to be rather smaller than the standard 1214 taper, but it says here rather smaller dimensions, comparatively smaller diameter, and comparatively short V40 taper. Now, all of that making it smaller diameter, shorter, has again reduced the surface area for fixation at the taper junction. Not content with reducing the surface area available for fixation, all the companies now put grooves and ridges down their tapers. Now, why do they do that? That's because all companies' neck tapers have to pass a burst test with ceramic heads. If you fail the test, then Ceramtech or whatever ceramic manufacturer will not supply the orthopedic company with ceramic heads. In order to pass the burst test, the company has to put these grooves and ridges on the taper, and these increase the frictional resistance between the taper and the inside of the ceramic head, decrease the bursting stress, and the company supplies the orthopedic company with ceramic heads. On the left, I've shown a BHR articular surface for comparison, and on the right there is a neck taper, and you can see the grooves and ridges. There are two aspects to this. By having all these grooves, this gives an opportunity for fluid to collect in there, and this makes tapers a sitting duck for crevice corrosion. In addition, the available surface area for fixation of the taper junction has been reduced by approximately 50%. I'm going to talk now about frictional torque, which is the product of the coefficient of friction, the force applied, and the radius of the joint. Now that looks very happy in the coronal plane, but I'm now going to swing that through 90 degrees because our man working out in the gym, doing these deep squats with a massive weight on his shoulders, will apply that frictional torque at 90 degrees to the plane of your laptop that you're watching this on. And the frictional torque contrives to rotationally loosen the femoral head on the taper junction. How do we measure frictional torque? This is the friction rig at Smith & Nephew Warwick, and these devices use pressurized hydrostatic bearings which generate negligible friction, and you can thus measure the frictional torque at the couple. Now, my colleagues have published on this in the past, and here we're looking at metal bearings with varying clearance and the effect of the lubricating fluid. Here we're using serum with carboxymethyl cellulose or serum with carboxymethyl cellulose and hyaluronic acid. And the friction factor is undramatic here, and when you convert that for a 50 millimeter head into frictional torque, that comes to 6 Newton meters of frictional torque. How is a taper junction tested? This is the apparatus to test a taper junction according to the ISO standard. A load of 1,000 newtons is applied, and then torque is applied to the taper junction until slippage occurs. Here we have some typical test results, and you can see that we have a happy situation here. The bearing is generating 6 Newton meters of frictional torque, yet the taper is capable of resisting 40.9 Newton meters. So that gives us a good safety factor of 6.8. But what's reality? Does the hip have 1,000 newtons of load pass through the head all the time? Absolutely not. We all know about microseparation, and there may indeed be situations where the head is subjected to negative axial load. So 1,000 newtons of constant load is not reality, Further, the frictional torque is a function of a lot of these factors, all listed below. If you test the taper junction again without 1,000 newtons of axial load, you get very different numbers, and they are much lower. I draw your attention specifically to implant number 12, where the torque at failure was 10.5 Newton meters. Now here we are testing different fluids. We've now put blood into our metal-metal joint, and this has been presented at the ORS in the past, and you can see that when blood is in the bearing, and of course it always is following surgery, then at low clearances the friction coefficient is really quite high. Now it is interesting that the devices that are showing up with taper failure initially are the ASR, low clearance, the Pinnacle metal-metal, low clearance, and the Duron, low clearance. Now when you convert that through into frictional torque, at 2,000 newtons of load, the frictional torque is 11 Newton meters. Now that means that even with 2,000 newtons of load, we have arrived at 11 Newton meters of frictional torque, and that will cause one of those tapers to fail. Is the problem solely one relating to metal-metal bearings? I'm afraid it is not. This is an excellent piece of work published from Boston in 2006, and they did a very thorough examination of frictional torque in aged conventional and cross-linked polyethylene at varying head sizes. Here you can see the massive work that they've done, and the first thing you need to notice is that the frictional torque increases as the axial load increases. Now, of course, they've taken their axial load up to 3,000 newtons, but we know from Bergman that 8,000 newtons represents peak load, so the frictional torque would obviously go higher. I want to walk you through the results that they obtained at 3,000 newtons. First, we have a 22 millimeter unconventional poly. Then we have a 22 millimeter head on crosslink poly. Then we have a 28 millimeter head on conventional and a 28 millimeter on crosslink. Look at the doubling of frictional torque on a 28 millimeter head by going from conventional polyethylene to crosslink polyethylene. Then we have a 32 on conventional, 32 on crosslink, 36 on conventional, 36 on crosslink, 40 on conventional, 40 on crosslink. Now, apart from the 22 head, crosslinking significantly increases the frictional torque compared to metal on conventional polyethylene. So with these metal on polyethylene, what frictional torque do we expect? And the first thing to notice is that with that 36 millimeter head on crosslink polyethylene, the frictional torque generated is 11.5 Newton meters. So that means that even at 3,000 newtons of load, that already exceeds the torque capability of one of those tapers. Now, this is all very scary, and have we any way of validating this information? Has, for example, the aging that's been done on the polyethylene somehow increased the frictional torque at the couple? Well, my colleagues at Smith & Nephew have looked at a cobalt chrome head on a non-aged, regular, conventional polyethylene with a 32 diameter. And what you find on the first cycle is 4 Newton meters of torque, and on the 60th cycle it increases to around 6 Newton meters of torque. Now we think that increase from the first cycle to the 60th cycle is to do with creep of the head into the polyethylene. If we just go back and look at the 32 millimeter head on aged conventional polyethylene on the Boston results, they got 5.5 Newton meters. Smith & Nephew lab got 6 Newton meters. So there is broad agreement. So those high levels of torque measured at 3,000 newtons with large heads are likely to be reality. And of course, as I already pointed out, 8,000 newtons is peak load for the hip. Part of the Boston experiment was to test the 40 millimeter heads in a hip simulator. And here we can see the locking mechanism looks great after 20 million cycles. Now this is with cross-linked polyethylene, and they showed convincingly that aging cross-linked polyethylene does nothing. Cross-linked polyethylene is made by irradiating conventional polyethylene with 100 kilograys. That cross-links the amorphous phase, but you are left with a lot of free radicals. And to get rid of those free radicals, there are 2 options. You can either anneal it, multiply anneal it, or remelt it. And the first generation cross-linked polyethylenes are treated with remelting, which totally gets rid of the free radicals. Annealing doesn't reduce the mechanical properties as much, but it does not fully get rid of the free radicals which hide close to the crystalline phase. The point is that when you cross-link poly and treat it to get rid or minimize free radicals, the mechanical properties are deteriorated compared to conventional polyethylene. If the cross-linked polyethylene is too thin and you insert the cup too vertical, then the cross-linked polyethylene can fracture. Now, something disturbing is happening with cross-linked poly. There are 2 reports out of Gothenburg, and both of these are RSA, one on a cemented cup study and one on a cementless cup study, and both show the same thing. Cross-linked poly wears very well, according to RSA, up to 5 years. But between 5 years and 7 years, there is an increase in the penetration of the head into the poly. Now, the 10-year results of this RSA study will be available later on this year, and that is going to be very important to us all in estimating what is going to happen to cross-linked poly with respect to particle disease, because roughly 3 million of these implants have been inserted. However, retrievals of the first generation cross-linked polyethylene show that bad things are happening. The cross-links are breaking down, exposing free radicals. Why is that? That's because fat ingresses from the synovial fluid into the polyethylene, breaking down the crosslinks. A further reason is local high-stress concentration breaks down crosslinks in the polyethylene. Now, that's bad, but how could you make it worse? If you had a large head, then you would have an increased surface area for fat to ingress from the synovial fluid. And if you have a large head with a thin poly, then you would contrive to cause local high stress concentration in the polyethylene. The really bad news is that recently a 10-year retrieval of first-generation cross-link poly has shown oxidation. And I'm sure we're all going to hear a lot about this over the next couple of years. In the Boston experiment, when they aged conventional polyethylene, as shown on the top two photographs, then oxidation with white lines occurred. But when cross-link poly was aged, as shown in C, then no oxidation occurred. However, the new information is that at 10 years, cross-link polyethylene does oxidize, and there are implications of this. One of those implications is that we can expect locking mechanism failure to occur. In the Boston experiment, when the aged and oxidized conventional polyethylene was tested with a 40 millimeter head, then at 7 and even worse at 12 million cycles, the locking mechanisms failed. So things are not looking great for cross-link poly at the moment. With time, it seems that the linear penetration is going up between 5 and 7 years. There is clear evidence that big heads and cross-link put the frictional torque up to a level that may cause failure of the taper junction between the head and the neck. And further, the torque has been shown in this experiment to cause failure of the locking mechanism when the polyethylene oxidizes. With metal on metal, what to expect? These are results from the experiment at Smith & Nephew Warwick under adverse circumstances, and they've measured up to 15 Newton meters of frictional torque. This, of course, is enough to cause failure of the taper junction, but what I haven't shown you in all these experiments is that you can dramatically increase the frictional torque in a metal-metal bearing if you decrease the clearance. And it is, I stress, the low clearance metal-metal joints that are showing up first with failure at the neck taper junction. Here's an example of a failure. This cemented polished tapered stem shows serious corrosion on the surface. Now this stem came loose, and possibly the reason for loosening in this particular stem was increased torque. But there is corrosion at the neck taper junction. On the bottom you can see the machining marks inside the femoral head, and these are the original machining marks. Everything above that is metal that has been corroded away. Now you can see another pattern emerging at the top left. You can see bigger longitudinal ridges and grooves, and interestingly this happens to be the same characteristics as the grooves and ridges that are on the neck taper. So it appears that the neck taper is corroding its way into the femoral head taper. This is a neck taper failure with an ASR, metal-metal turtle hip, and you can see in the shiny area the original machining marks. But at the junction you can see that the original machining marks have disappeared and all that metal is corroded away. Now there's been attempts at measuring the amount of metal that's worn stroke corroded away, and it is higher than a metal-metal joint produces with 15 years of normal wear. And regrettably, failure at the taper junction is causing the same sort of soft tissue pseudotumors that have been described from Oxford. So you may, for example, put in a non-metal-metal bearing, but still get taper junction failure and pseudotumors due to an excess of metal debris generated from the failed taper junction. Where do we go from here? Taper junctions clearly cannot remain the same. We know of problems that are occurring now, and massive problems will emerge over the next 2 years. We can either go backwards or forwards. We can go back to monoblock stems and heads, and clearly these will eliminate the taper junction problems. But the lack of modularity will be very hard for us to cope with now that we've got used to the flexibility of having modular heads. If we are to move forwards and move forwards with safety, we must develop tapers that are rotationally stable. And this is an example. We could put a series of flats on the cone, and these flats would resist torsional failure. It would have the advantage that we could use a taper with such flats to insert an eccentric sleeve, and by dialing in the required position we could change offset, leg length and version. Crosslink polyethylene is looking very suspect at the moment, and we cannot risk staying the same. We either move backwards or we go forwards. If we go backwards, then there's a very good case to be made now for moving to a 22mm head on conventional polyethylene. Sir John Charnley got it right, and I think that those of us who are at this conference in 20 years from now will say again, Charnley got it right. If we move forwards, we must develop a better crosslink polyethylene than exists today. It must not be weaker than conventional non-irradiated polyethylene, and it must be oxidatively stable in the long term. With metal-metal resurfacing, we are in a mess thanks to poor implants and poor surgery. And we must either move backwards or forwards. We can abandon metal-metal resurfacing and move backwards, but it's returning to the dark ages. If we are to go forwards with metal-metal resurfacing, we must eliminate poor design in implants and poor surgical implantation. Both of these have caused serious damage to patients and must be eliminated for us to successfully move forwards. I thank you for your attention.